Tobias, and I'm delighted to be chairing this session entitled All Sleep is Not Equal, Addressing Disparities in Sleep Health. So my goal for the next few minutes is to introduce this topic by outlining the scope of disparities in sleep health. And our subsequent three speakers are going to then tackle this important issue from a few different angles, including from the patient level, where we can consider ways to mitigate disparities in sleep health, the educational level, where we can discuss how to recruit a more diverse sleep workforce for the future, and the institutional level, where we can consider initiatives to promote diversity, equity, and inclusion. In all of these talks, our speakers today are going to be focused on describing not just how our current systems fall short, which is well acknowledged, but also some potential solutions. And we really have a fantastic lineup of speakers this afternoon, so I'm looking forward to everybody's talks. I have no disclosures. And the reason this conversation is so crucial is that disparities in sleep health contribute to disparities in overall health in socially disadvantaged groups. We have an abundance of evidence that shows historically marginalized racial and ethnic groups are disproportionately affected by insufficient sleep duration, by insomnia, by circadian disruptions such as the impact of shift work, and even obstructive sleep apnea, where socioeconomically disadvantaged populations are diagnosed at lower rates and often less successfully treated than their higher SES counterparts. So let me begin by just showing a few examples of the many ways in which sleep disparities play out in the real world. Studies show that increased levels of perceived racism are linked to increased odds of insomnia among Black women. We also have data that exposure to adversity early in life has long-lasting effects, impacting rates of insomnia and sleep duration even up to 50 years later. During the COVID-19 pandemic, Black young adults reported sleeping an average of an hour less than Asian, white, and Latinx young adults. Among college students, African Americans are more likely than whites to report short sleep duration. And thinking more broadly about other marginalized groups, we can consider sexual minorities who report poorer sleep overall and a greater likelihood of reliance on sleep aids. So what factors contribute to differences in sleep health across different groups? These relationships are, of course, complicated and multifactorial. Sleep health is impacted by socioeconomic status, including income, education, and occupation, including prevalence of shift work, by the built environment, including inopportune light exposure, noise, and ambient temperature conditions, by social factors such as neighborhood disorder, crime, trauma, culture, and the demands of family caregiving, access to healthy lifestyles like food equality and opportunities for physical activity, access to health care, including diagnosis and treatment of underlying sleep disorders, and finally, even environmental irritants such as pollution and tobacco exposure, which have been linked to higher rates of sleep apnea. So considering all of these factors together, you'll notice that, of course, some of these may be more easily modifiable than others. And a number of our journals have highlighted these issues of sleep disparities recently by dedicating special issues to the topic or creating special sections within their website that are devoted to these issues. So I would urge you to check these out to better understand this very important work being conducted in this area. And finally, I'll end with a plug for our Sleep Network Open Forum, which is going to be held on Tuesday at 11 o'clock. This is a great opportunity to help plan sleep-related content for the 2023 CHEST meeting, to get some tips on how to submit a good session, learn about our new network structure, and to meet colleagues who are also interested in sleep medicine. And so with that, I want to turn it over to our next speaker, Dr. Andrew Spector.
Thank you very much. I'm happy to be here. I haven't been in Nashville in many years, so this is exciting. I got to walk around a little bit, and I'm really honored to be with these speakers today. I'm going to be talking about recruiting a diverse sleep workforce for the future. I'm an associate professor of neurology, so this is my first chest meeting, and I have nothing to disclose. So 3 goals for today. I want to make sure we talk about why diversity is necessary and sort of set the stage for why we're even having this conversation. Then we'll review the current status of racial diversity in sleep medicine and explore ways for fellowships to attract and match diverse applicants. And when I talk about diversity today, we're talking about diversity in a broad sense. And that's not just race and ethnicity, although we will actually talk a lot about race and ethnicity, but also gender identity and sexual orientation, age, religion, and everything you see here, all reflected in the diversity of our sleep fellows. So why does this matter? Well, first of all, we do 3 things in academic medicine. We provide patient care, education, and research, and it's the 3 missions that we're all part of, and diversity is important for each of these. So let's start with patient care. We know that underrepresented physicians are 3 times more likely to treat underserved populations. And although I certainly wouldn't argue that it's the responsibility of underrepresented physicians to do that, it is the case that they do at this point. We also know that racial concordance between patients and physicians enhances the patient perception of care, and that those institutions with more racial diversity are perceived as more trustworthy by their communities. So patient care is improved when we have more diverse care providers. Also in education, we know that faculty of color are more likely to employ active learning, encourage student input, and include more diverse perspectives in their courses. And students who interact with more racially diverse peers show increased engagement in their education. And finally, in research, the more diverse a research team is, the more productive and creative the outcomes. And those diverse teams demonstrate a higher level of critical analysis and broaden the research agenda, have more citations and higher impact factor publications than homogeneous groups. So whichever area we look at, whether it's education, patient care, or research, all 3 of them require diversity to achieve excellence. So where do we stand in sleep? These are the numbers from the AAMC. So this is active in GME right now in our sleep fellows. What we're looking at is comparing the internal medicine as a feeder specialty to sleep medicine. And you'll see that in blue compared to sleep in orange. Now you'll see sleep is a little less white and more Asian than internal medicine. But when we look at the 4 racial groups that are underrepresented, we have Hispanic, Black, Native American, and Native Hawaiian. Sleep lags behind internal medicine on all 4 of those, and sometimes substantially. This is a graph with neurology, another one of our feeder specialties, and we see here that, again, neurology is substantially outpacing sleep when it comes to diversity. So even if we were to match our feeder specialties, or if we were to compare ourselves to our feeder specialties, we're lagging significantly behind when it comes to racial diversity. And I want to point out that even though it looks like here, we'd say, okay, if Black fellows represent 4% compared to 6% in neurology, our goal is not to go from 4 to 6%. This is actually the percentage in the United States. And this is really what our ultimate goal is. You see, we're way behind what our actual goal would be. So even if we were to achieve parity with our own feeder specialties, we're still way behind in the diversity. So what are we going to do about it? Well, let's start at the fellowship level, and let's talk about what it means to recruit diverse applicants to the fellowship. And I talk about a stepwise approach to building diversity in your programs, and that includes starting with a self-assessment, branding and marketing your program, how you review candidates, making offers to those candidates, and then ensuring when they get there that there's a positive experience, because nothing will sabotage the whole process more than providing a bad experience when you actually do recruit these candidates. So first things first, we don't want to put the cart before the horse. If you're not supplying an inclusive environment, then there's no point in trying to recruit diverse applicants, because it's not going to be successful. They'll pick up on that during interviews, or if they do come and match at your program, they're not going to be satisfied. So it's important to make sure that you work on the inclusion element of your program before you even try for diversity. So how do we start with these self-assessments? First, who's responsible? As a program director in a fellowship, you take some responsibility in this. If your academic department has an equity, diversity, inclusion officer, they can certainly help. And then ultimately, everything comes down to the chair. And the chair needs to be responsible, particularly because they need to provide you the budget and the time to do this work. This isn't going to happen for free. So once you've got the team, maybe the program director and the diversity chair, you start looking at the current climate in your department or your division and find out what the experience is like, see where you can improve. And then you need to look at your own program and say, okay, are we getting diverse applicants? And if so, are we making sure that we're interviewing diverse applicants or are we turning them away? So do a self-assessment on your own recruitment process. Some examples from Duke where we've done this. We did a departmental census, and this tells us all the areas our department is diverse. So we looked at religion and politics and pet ownership, and you name it, and established all the different dimensions that we could identify to see where we were diverse and where we were lagging. We did a gender pay equity study to make sure that we weren't paying our faculty different amounts based on gender. We looked at our grand round speakers. Are we inviting guest speakers that represent diverse perspectives? And again, residency recruitment. This was a big one for us because we realized that we were not, in fact, recruiting a diverse set of applicants, and we had to figure out why. And so we did that and found that it was, in fact, our process that was failing, and we were rejecting candidates for things that really probably didn't matter. So that was published, and you can actually probably find that online. We did a diversity and inclusion satisfaction survey because we needed to know where we were doing well and where we were falling short of our expectations of ourselves. And so all of this is available. We put this online so that our candidates can see what we've done to try to improve our environment for them when they get there. When it comes to branding and marketing, you got to put yourself out there for people to find your program. Where do you advertise? What message are you sending with your website? What documents do you provide in advance? And are you publicizing what you're looking for in your applicants? So there are all kinds of ways you can advertise. The American Academy of Neurology or CHEST, you have a presence here trying to recruit for your fellowship. And then there's the societies like the National Hispanic Medical Association or the National Medical Association. There are historically black med schools which don't have sleep fellowships. So if you're nearby, you can reach out to your local HBCU medical school and try to include them. And then, of course, there's social media. Twitter is one. An example on Facebook would be the Society of Black Neurologists, and they would advertise for you. You have a job posting, you're looking for candidates, you can actually reach out and they'll post your job. What are you going to put on your website? So I talk about putting out job descriptions that avoid gender bias. That's a really big one because words like aggressive and strong in your job descriptions can actually steer who applies to your program. And then I always like to include a welcome letter. So I happen to also be the vice chair for inclusion and diversity in my department, so I'm doing double duty. But for all the other fellowships that in our department, those applicants also get a letter from me explaining what our philosophy is, how we're going to provide a good environment for them, and also a D&I resource list. So in this case, who do you go to if you have a problem? Where do they find the policies and the statements, and provide this up front so people know that we take this seriously. And then we make sure that we have on our website our commitment to equity, diversity, and inclusion in a formal statement from the department. And then, as you saw from the previous slide, we list all of those things so people can review them on their own time and ask questions about them. Once you've gotten people to apply, how are you going to choose from among all of these candidates to make sure that your candidate selection is not biased? Because this is a real problem. And when we're looking at applications, when you open your ARS to look through the applications, the first thing you're going to see is the candidate's name. And there's ample research. Here's one example, but there's ample research that name alone can influence whether or not they're going to get an interview. So this was a study done over 10 years ago looking at changing just the name on an application. And if you just substitute the name and leave everything else the same, those names that were more stereotypically white got 50% more callbacks than those names that were stereotypically black, and the only thing different is the name. So sadly, we cannot blind ourselves to the name. Letters of recommendation include names. We can't undo that. So we just have to compensate for that and be aware of this bias. There are other biases throughout the application that we need to be aware of too. So even though we consider tests to be our objective measure, the reality is that test questions can have bias in them. And I have a picture there. Many of you probably know what that is. That's a roll of sod. And I grew up in Michigan, and there was plenty of sod to be had. But I put that there because I grew up hearing the story from my dad, who grew up in Manhattan. And he came to Michigan. He's an attorney, and he had to take the bar exam in Michigan. There were questions about sod. And he had no idea what sod was. He didn't know the word, didn't know the term, couldn't answer the question. And so as objective as we think our tests are, sometimes it has nothing to do with the law. He didn't struggle with knowing the law. He struggled with understanding the cultural reference that I'm sure nobody intended, but that's what it was. And then we know from that one of the best predictors of success on standardized testing has nothing to do with academic qualifications and everything to do with parental wealth. The SAT and the MCAT, the #1 predictor of your score is how much money did your parents make. So when we rely on our tests to tell us who the right candidates are, there's an inherent problem with that. So let's look at the other things. What about grades? Well, you're looking at applicants who rotated with who knows who. You don't know the faculty and what biases they may have had, and those get translated into grades. So you never know what you can trust with the grades, so that's a problem. Letters of recommendation, there's plenty of research suggesting gender bias in letters of recommendation, and regardless of the gender of the author, the subjects of the letters have a gender bias, and so women are more likely to get comments on their personalities and men on their skills, and that's going to translate into who actually you're going to want to interview when somebody is told that they're good at what they do versus they're a nice person. And if you're looking at reputation of med school, well, you've got trouble there too because you don't know the admission policies of the med school and what may have been biased in those admissions. And then remember that if you're looking at leadership positions, some of these are elected. And what did it take for them to get elected? Or how about sponsorship? Did everybody have equal access to sponsorship to do those research activities that we like to prioritize? So there isn't really any one element that's entirely free of possible bias. So what are we going to do? We have to compensate for this because we just don't know which biases might be playing a role when we review an application. This is why we talk about holistic review, because when you do a holistic review, you try to mitigate that bias because you're spreading it out among all these different elements, and you're using a score sheet that allows you to numerically translate some of these things and not overly rely on any one element like a board score or a grade. And so when you're building a holistic review process, start with the minimum skills that are required for the job. What do you need? You need somebody who's a good team player, or you need somebody who is skillful in certain procedures. Whatever you're looking for, whatever you need to do the job, you list that out, and then you can go farther. Okay, what would make this person not just meeting the minimum, but what are the extra things that we want in a candidate? And when you go to build your score sheet to review the application, the things you need get more points than the things you want. And so applicants can build points based on what they bring to the table. One of the tricks to this is identifying how to score things you're looking for. So you want to know if somebody is a good team player. You got to figure out where to look in the application to figure that out. Is that going to be in the letters of recommendation? Is that going to be in their extracurricular activities? They played a team sport, something like that. So you got to figure out where are you going to look for those elements that you need and that you want, and then give credit for what you find. And I always say, don't take away credit for things that haven't been done. So this is every achievement that candidate has, they get credit for, but things they haven't done, you don't necessarily penalize them for because you don't know the circumstances. Were they not sponsored for a research project, for example? When we're reviewing applications, ideally 2 sets of eyes are going to look at these applications. Now, that's not always feasible, and sometimes it's just too many applications to read through them all twice. I get that, but it would be considered best practice to have 2 reviewers. Now, I strongly urge people to actually blind themselves to race and gender up front to protect yourself from any potential biases that you might have. And most importantly, the photo. There are still programs out there that have the photo front and center when they're reviewing the application, and I cannot think of anything that matters less to the quality of the applicant than their physical appearance. We know that photos of people based on physical biases, like, for example, somebody who's deemed to be overweight or even women with short hair are less likely to get interviews. And these are ridiculous. We don't need to see what a person looks like, and the application does not need to show you that. You can blind yourself to photo. So that's an easy, low-hanging fruit. Don't look at the photo before you decide if you're going to interview someone. Score the application using that score sheet you spent time building, and then you can unblind. Now everybody has a score, and you can unblind. And I would bet that you actually probably don't need to do much. You're going to have achieved diversity through this means. We've tested this out in our programs, and actually that achieves parity with the number of applications. So when we look to say what percentage of underrepresented groups applied to our program, even without having to do anything else, we got markedly more diverse when we started doing this process than when we were doing a more gestalt thumbs up or thumbs down when we read the application. But race can be a tiebreaker. What's going to happen is you'll have a whole bunch of people that you could interview. And it is perfectly legal to say, you know what, I want to diversify my program, and so the edge goes in the tiebreaker system to people from diverse backgrounds. And that could be diversity, again, not just race, but maybe you don't have anyone else who's the first-generation college student or an immigrant background or anything you want to use, you can use in that regard. So then it comes upon the interviews, and I urge people to highlight what makes your region appealing. So is your region racially diverse? Let people know that. Is it very friendly and welcoming to the LGBTQ population? Let people know. Find what your region has to offer and highlight that. And I also encourage people to find interviewers who are comfortable speaking about these topics, because you need to be able to have this conversation and discuss these things openly. And I'm going to focus a little bit on speaking about race right now and say it is okay to talk about race in an interview. And in fact, I think you should, because it's important to talk about it with everybody. What I don't want is for you to spend time, you've got limited amount of time in an interview, maybe 20 or 30 minutes max. Don't only use that time with candidates of underrepresented backgrounds to talk about race. That's not really fair to use up their interview time on these topics and not other people. But I think it's great to say, okay, if there are reported microaggressions, this is how we deal with it in our program. And there is no one who shouldn't hear that. So I'd say spend time talking about this with everybody. And it's going to be obvious if your program is not terribly diverse, it's okay to say it. And I've said this to applicants. I say, I know we don't have very many faculty of color. This is the strategy I've got. This is what we're trying to do to change that. But I'm open about it because they can look on our website and figure that out. There's no point in trying to pretend. So acknowledge the existence of racism. I believe in this. I cannot protect every applicant who's coming to our program from experiences of racism. It's bound to happen. It just does. And I can't prevent everything. But I can tell them, I will trust you when you report it, and we will respond swiftly as needed. And so I can assure them of that. I can't assure them that they will never experience racism, because no one can really do that. So I talk about my response to it more than saying that oh yes, you'll have this great experience, because I can't promise that. And I would never advocate emphasizing diversity as the goal. We recruit people, we don't recruit for any particular race. That's just not how it makes sense. And then if you have organizations in your institution, like we have a Duke Minority House Staff Association, which may consider changing its name, because I'm not a fan of the name, but we also have a House Staff Association for Sexual and Gender Diversity. And so we highlight these to all of our applicants, because I don't always know how people identify, and so I make sure every applicant knows that these are available to them. When it comes to ranking and match lists, be careful about this idea of fit. Most people have probably heard this by now, that fit can be code word for like me, and you don't necessarily need a program of people like me. And when you're looking at your overall match list, you can be conscious of diversity, and what you don't want is your diversity at the bottom half of that rank list, right? So make sure that your rank list reflects what you're looking for in your program. And then when you've recruited, now we have to support, because we don't want people to come into our programs and have bad experiences, because it's going to be really hard to recruit the next generation after that. So we have to be ready and able to provide mentorship and sponsorship, and particularly be alert for imposter syndrome, know how to coach people through imposter syndrome, and then be alert for the diversity tax. I tell people, look, I'm the vice chair for inclusion and diversity. You are not being brought in to do this work. If you want to help, great, but you do your residency, your fellowship, your faculty job, whatever you're being brought in to do, that's what you do. Let me take care of this, and I'm happy to have your help if you want, but that's not your job. And I make sure that they know that up front. And also be alert for tokenism, because nobody wants to be put on a poster just because they have a different skin color as someone else. So we actually have a written policy about how we generate our promotional materials to make sure that doesn't happen. And so I'll summarize: be proactive in recruiting, because it doesn't happen by just sitting around and waiting. Review your recruitment materials, make sure you're sending out the right signals. I advocate blind, holistic review based on the pre-established criteria, but then unblind and make sure that you've achieved your diversity goals. I definitely discuss our anti-racism work in our interviews, and then make sure you're supporting trainees with special attention to the barriers that are most likely to affect particularly those coming from more marginalized communities. So thank you very much. Dr. Tobias, I'll turn it back over to you.
Thank you so much, Dr. Spector. And we're going to save questions to the end for the sake of time. So next, I'd like to welcome up Dr. Dana Johnson, who's going to share with us some novel interventions to reduce sleep health disparities.
Thank you. So my talk is really coming from the research perspective. And so I won't spend a lot of time here, but there are several determinants of sleep disparities that are multifactorial, and we see these across the life course, from in utero across aging. And so for the interventions that I'll talk about today, they mainly focus on the social determinants. And so many of these were highlighted at the start of this session, but I'll mainly talk about discrimination and stress, how to intervene there to reduce sleep disparities. But there's also interventions that can be at the environmental level. And so these tackle some of the features of the environment, such as light, temperature, noise, housing, and such. And I'll give a brief example of that. And then there are individual level determinants that are really the results of structural factors. For example, things like consistent bedtimes. So we know that this is the result oftentimes of parents who work multiple jobs, because a minimum wage is not a livable wage. And so they end up working multiple jobs and thus are not home to implement consistent bedtimes with the children. So again, the intervention there would be at the structural level as opposed to the individual level, but these are still factors that can be addressed across these different levels. And so these can individually and cumulatively contribute to disparities in sleep health and disorders. And so this slide is, I'm showing this as an overview of the different types of determinants or the different types of interventions to tackle some of those determinants I mentioned on the last slide. So one approach is to increase screening and treatment among the populations that are most at risk. Also, you want to target the determinants of poor sleep, and so that could be stress and discrimination, racism, which I will discuss. And then also conduct multi-level interventions. This can be at the neighborhood level. So there's data showing things like cleaning up a neighborhood reduces crime, increases safety, and we know that's associated with better sleep health outcomes and overall health outcomes. Also, we can design homes to promote sleep health, and here are some of the features of the home that can be targeted. And then also reducing light pollution in the home and also at the neighborhood level through the use of things like shielding within the neighborhood. We know that there are brighter lights in certain neighborhoods, particularly those of lower income. This was intentionally designed that way to deter crime, which it is effective at doing that, but it's less effective for the individual in terms of sleep, because these individuals typically do not have blackout shades, right? So there's shields and such that can be used outside public housing and such to reduce the light exposure inside the homes. And then also promoting safety. And then lastly, eliminating things like homelessness and promoting housing security. And so here is an example of a multi-level intervention to target sleep, where you have the individual at the center. And for this particular intervention, there was a sleep education program that was delivered to individuals in the community. And then there was a media campaign around healthy sleep habits. And then they place local sleep medicine specialists within the community. So this reduces the barrier for things like transportation for people to get treatment. So placing sleep medicine specialists in the community where the need is really effective. And then they're taking all the results and translating the knowledge into policy level. So let's talk a little bit about screening. And so we know that obstructive sleep apnea in particular is highly prevalent among populations that are historically minoritized. And so particularly Asian and Black populations have the most severe sleep apnea. And so what my colleagues and I did was design a screening tool for African Americans. And so this was using data from the Jackson Heart Study, which is a large cohort study of 1,000 African Americans, where we collected in-home sleep apnea testing as well as actigraphy. And so we were able to take the data from that, as well as some of the other things we collected from questionnaires and also anthropometry. And we fit different models using some different statistical techniques to figure out which variations of these different variables were most predictive of sleep apnea. And so we took our model, which is listed as models 1 through 5, and compared it to the commonly used screening tools such as the stop bang score, the NOSAS, and we found that the models that we developed with specific features to African Americans were more predictive, and you can look at our accuracy here, ranging from 72%, from 72 to 74%, compared to the stop bang score, which was 56%, and 66% depending on the level. Also the NOSAS. So we see that this tailored screening model was more predictive of sleep apnea. And then this was also compared to the Hispanic Community Health Survey. They also developed a prediction model targeted at Hispanic Latino populations, and also similarly found that their model was more predictive of sleep apnea in comparison to these others. And so our model for African Americans were slightly more predictive than using the Hispanic Community Health model. And so ours, and as well as the CHS models, are all available online. This is something you can go to the website, put in this data, and get a measure, a percent risk for sleep apnea. And so now I want to move on to talk about how to develop tailored interventions. And so again, one of the initiatives that my group has taken is tackling some of the most predictive variables and factors of sleep health disparities. And so we know that racial ethnic minority groups are disproportionately burdened by stress, anxiety, and insufficient sleep. And in particular, Black and Hispanic populations have report more stress and anxiety in comparison to non-Hispanic white populations. And we also know that these same groups have worse sleep quality. And so we took that information and then also went in the literature to understand more about interventions. And we found that, of course, meditation, and particularly mindfulness-based stress reduction techniques, are successful at reducing stress and anxiety and also improving sleep quality. However, there was a lack of studies that were tailored to African Americans or Hispanic communities. And so we developed a study called the Mindfulness Intervention to Improve Sleep and Reduce Diabetes Risk among a diverse sample in Atlanta. We call it the MIND study. And so the results I'll show you, you'll see nothing about diabetes. That was our original design before COVID, when we were bringing people into the clinic and doing blood draws, and then we had to pivot a bit. So we changed our outcome to be blood pressure and weight, and we delivered scales and cuffs to the porches of the participants. And so our goal was to improve sleep and reduce cardiometabolic risk using a mindfulness and sleep education intervention. So we enrolled men and women over the age of 18 that lived in Metro Atlanta. Again, they needed to be local so we can deliver the tools for the study. And also for our eligibility criteria, we enrolled only those that have poor sleep quality as defined by the PSCI. And so all of our participants completed a 30-day mindfulness meditation intervention, and we used the Headspace app. And so this is a timeline just showing what the participants engaged in at different points of the intervention. So at baseline, we measured weight and blood pressure. We also had the participants complete a series of questionnaires on sleep, stress, other health behaviors such as diet and physical activity. And then we also started them with actigraphy. And then, so each person had at least 3 days, including a weekend, before the intervention visit, where we talked about the Headspace app and educated the participants on which sessions to complete, those focused on stress and anxiety. And then I delivered a sleep education hygiene session where I discussed healthy practices for optimum sleep health. And so 15 days later, we brought them back in, did some questionnaires. We checked the actigraphs and make sure they were collecting, recharged them, gave them back to the participants. They did another 15 days, and then we measured their weight, blood pressure again, completed questionnaires, and we ended the actigraphy. And then we had them participate in a focus group. This is a mixed method study, so we were interested both in knowing quantitatively how things may have changed during the intervention period, but also knowing qualitatively about their experiences. And so the intervention was 30 days. And so here's the demographics for our study population. This was a pilot study, so we enrolled 17 participants, most of which were female at 88%. Most of our participants, over half, were identified as Black. We also had 12% identify as Asian. And then in terms of marital status, we had about 41% that were married. Most of our participants on average were overweight. And we also had a very educated sample. This could be a function of where we recruited, mainly on the Emory campus, and also using social media. And so you can see here where most of our participants had a bachelor's degree or higher. And the average PSCI score was a 9.2. Anything greater than 5 is considered poor sleep quality. So in terms of our quantitative results, we saw over the course of the 30 days that the individuals overall reduced in their perceived stress scale score, so they reported less stress at the end of the intervention. They also had a lower PSCI score. You saw the average on the last slide was about a 9. At follow-up, it was about a 4.2. And then we also, as I mentioned, did actigraphy. And so we found overall that there was a reduction in sleep duration, an improvement in sleep efficiency, and a reduction in wakefulness after sleep onset. So some of the estimates are a little bit smaller, but we do see that there's a reduction, and with a larger sample size, we expect to see even larger magnitude. And so I want to show you some of the results from the qualitative data. So we did a series of focus groups. We did these across waves. So we did 4 different focus groups. And the topics that we discussed were reflections on the app use, the ease of use, level of fit with lifestyle and routine, barriers and facilitators, perceived benefits, And then we asked them about things they would change, so app modification and tailoring, and then attitudes and beliefs about sleep. And so in terms of app acceptability, most participants found that it was pretty easy to use, particularly for stress and anxiety relief. And they also reported that it reduced sleep awakenings at night. Most of them found that that they would have preferred more personalization, and I'll show you some data around that, but they did like the app aesthetics. And then in terms of the feasibility, some of them felt that it was infeasible with competing priorities. It was actually hard to do. We asked them to do it at night, and it took about 10 to 20 minutes, depending on which sessions that they were completing. And as I go through the different points, you'll just see different quotes from the participants. So in terms of our results, we divided it by those that were less than 50% adherent compared to those that were greater than 50% adherent, meaning they completed the number greater than 15 sessions across the intervention time. So those who did less than 50%, had less than 50% adherence, still reported a stress reduction, whereas this person said, I want to live a life that's less stressful. And so for those that had greater than 50% adherence, they were more likely to report a reduced time to fall asleep. And you can see this is consistent with our quantitative data. And so in terms of the facilitators, some of them reported having some experience with doing meditation. So those that were less adherent had prior experience. And so those that had greater than 50% adherence, some of their facilitators included the flexibility. So although we asked them to do it at night, if they couldn't, we said do it whenever works well for you. And then also having this intention around completing it. And so some barriers included difficulty with the app navigation, navigating the app, and then also some reported that the timing wasn't quite right with their working schedules. And then others reported there was a lot of material and a poor fit with evening routine. So that was consistent regardless of their adherence level. But what I really wanted to focus on or highlight is some of the experiences of our racial ethnic minorities. And so they appreciated the diversity of the meditation instructors, and they were most likely to choose an instructor that was the same race and gender. This is very consistent with the data that Andrew just presented on concordance being important. And then overall, some of the things that they wanted changed were things like they wanted more notifications, a personalization of the app, a different playlist. And then particularly for the Black participants across the board, they all reported wanting an introductory guide and then also additional educational resources. And so also along that racial ethnic minority experiences, as I mentioned, they prefer doing these sessions with the instructors of the same race and gender. And they also asked, and because we asked for pointers for designing our own app, that they specifically wanted the same race and gender. So for the Black men, they wanted to hear a Black man giving the meditation. And then for the Black women, they said the same. They wanted a Black woman to deliver it. So they were very, they advocated a lot for those modifications. So we found that this was feasible to do in terms of delivering this app and sleep hygiene. And we found that race and gender concordance was very important for minorities. Other groups, so the white participants did not report that at all, and it wasn't something that they found to be important for their use. And so again, this emphasizes the importance of tailoring interventions. And so I'll end with showing some results from an intervention that was done at NYU. This was not something I was a part of, but I've read a lot about this study, and I think it's a really good example, and I wanted to share these results. And so this study, they designed a health communication focused on obstructive sleep apnea for African American and Black individuals. They did focus groups with patients, providers, as well as stakeholders to learn more about their perceptions. And so this represented their groups of those that were involved in the development of this intervention. And so based on the formative research results, they developed this web-based intervention, and they filmed narrative videos with patients and developed messages to address specific barriers. And so this is a picture of one of their participants. Here's a picture of the website where you can see the testimonials. You see information about sleep health, sleep apnea, and the sleep test. The most important thing is that individuals, patients, when they went to this website, they saw people that looked like them, so they could identify, and they were more likely to stay on the website. Here are some screenshots of the videos. And so in terms of their results, they evaluated self-efficacy for sleep apnea and found that there wasn't a large difference at baseline. Tasha's their intervention, they already had a higher score, and that persisted across the 6 months. But for their apnea knowledge test, you can see that the control participants had a higher score at baseline, but at 2 months and 6 months, their intervention groups had a higher apnea knowledge test. And then lastly, I'll end with a tailored insomnia treatment program for Black women. This paper was recently published in JAMA Psychiatry. And so this is using data from the Black Women's Health Study. They conducted a 3-arm randomized controlled trial using shut-eye. And so they modified shut-eye and tailored it to Black women. So they changed some of the scenarios and also had a physician that was a Black woman to deliver the education. They also had patient education as their control. And so they found that both individuals that were in the shut-eye group and the shut-eye, the Black Women's Health Study version, they all had a reduction in the insomnia severity index. But even more interesting, those that were in the tailored group, they were more likely to be engaged in the intervention. So again, showing that concordance for reduction of the sleep outcome. So thank you very much for your time. And again, we'll take questions in the end.
Great. Thank you so much for that talk, Dr. Johnson. And now we'll have our final speaker. So we have Dr. Vivian Asari, who's going to be speaking about strategies to improve DEI within your academic sleep program.
Hello, and thank you. Happy to be here today. So I'll talk a little bit today about strategies to improve DEI within your academic sleep program. I could also just change improve to creating. So this would be kind of the initial stages of doing this in your programs. I have no conflicts of interest to disclose. So I'll start with 4 strategies in improving DEI within an academic sleep program. And so building a team and discussing the mission, surveying the current climate, and by doing this, opening up communication and dialogue, planning and engaging, organizing, and then forming areas of DEI focus. And so building a team and discussing the mission is kind of key here. You're setting the stage, you're inviting everyone to participate. You want to kind of stress that DEI isn't only the work of few, you want to really invite and include everyone in your section. And you want to also include your leadership, because your leadership will really be the ones setting the stage, sort of setting the environment and the culture of your program, and also helping with sustainability of your program. And within that group, you want to really elect a leader. And in that group, that person will be really the liaison between the department, between the faculty, and will be able to kind of initiate these discussions, initiate these initiatives. And then once you have your team, you really want to create a mission. and you want to discuss this mission, be very concrete about your goals, what you hope to achieve with this group, and moving forward. And so I think this is kind of key in terms of starting and sort of improving a DEI program, is to survey the climate. So you want to tap into how people feel about DEI in your program. So in some programs, people might say, things are going great. Some people will say, okay, these are gaps, these are things that we need to work on, but the only way you'll know is really talking with your stakeholders, speaking with your faculty, your staff, your trainees, to see what are sort of specific topics that are not only relevant, but priorities. And so ways of doing this, so surveys, of course, are probably the lowest hanging fruit. This is something that can be anonymous, and so that's definitely something that would be a great sort of tool to utilize. A feedback box, again, sort of old-fashioned, but you could also do real-time questioning. So let's say if you're in a faculty meeting, audience response, you could put up a few questions, a survey, and people can kind of sort of be self-reflective on the program, what they think is lacking, and how to improve and move forward. So this is something specifically that our group has done. We had a retreat, and we had an opportunity to break out into small groups. And in these groups, we were able to have these real discussions, these DEI discussions. What are initiatives that you think our program would benefit from? What are things that you think are needed to improve and to move forward? And depending on the size of your program, this may be feasible, but meeting with individuals one-on-one to have a really personalized approach on talking about these topics. And so this is a sample DEI survey. This was from a group in the University of Michigan, and this was actually an obstetrics and gynecology academic program. And this was their initial sort of pulse survey. And questions like, our department is actively committed to issues of diversity, equity, inclusion. Things like the department's mission and vision include goals relating to our diversity, equity, inclusion values. So questions like these are nice ways to sort of, as a springboard, to get this information. And I like the sample DEI survey because it's very simple. So yes, no, somewhat, do not, do not know. It's a very, very simple approach to really garner some information that could be very useful. And so plan and engage. So now you've created your team, you've come up with a mission, you have your leader. So now basing these DEI initiatives on your mission, gathering, and also the gathered information from your surveys on sort of these prioritized DEI topics. And I think at this point, having these regular meetings will help with momentum moving forward. Including DEI updates, I think, in faculty meetings, really bringing in everyone, right? Including everyone, having DEI minutes, maybe in the beginning of faculty meetings, to really provide updates so that people know what you're working on, and hoping to really sort of ignite interest so that people can really work on these initiatives with you. And having a DEI newsletter. So we have a hospital-wide DEI newsletter that comes out every month. So we send this out to our faculty members, and this is something that really helps people get engaged. There's so much going on campuses, and so being able to pinpoint activities that people can get involved in is really useful. And so having DEI areas of focus, so this will be different for everyone, and this will be evolving for most people. And so in our program, we're focusing on recruitment and retention, mentorship, scholarship, and then inclusion and community engagement. And so I'll talk a little bit more about the scholarship portion of things and inclusion and community engagement. And so with our scholarship program, we're really trying to build our DEI curriculum for faculty, trainees, and staff. And so I put unconscious bias training first. We'll talk about that, but also things like cultural competency and awareness, various workshops, workplace civility, improving sort of the interactions between faculty and staff, and of course, building health disparities sessions and seminars in our grand round sessions. And so effective strategies in reducing implicit bias is really crucial, because we all know that implicit bias in providers is a reality, unfortunately. And so being aware of these biases and providing instruction on how to effectively overcome biases, challenge these biases is really critical. And so these studies that I've listed here talk about the combination approach. And so implicit bias training with active learning exercises for practicing these new skills is essential. And so things like perspective taking, common identity, self-reflection, these are sort of these active self-reflection tools that can be included with your implicit bias training that you can provide for not only your faculty, but also your staff and your trainees. And so with inclusion and community engagement, so I think community engagement is a really important part of DEI. I think, we're all here to take care of our patients. We're all here for them. And so you really want to be a part of their community and invite, provide different resources. And I'll talk a little bit about a patient-centered DEI initiative that our institution is working on. And so things to do, how do you create an inclusive environment for faculty, trainees, and staff? And so these are just examples, but, as Andrew had mentioned, one of the things you really don't want to do is to, recruit diverse people and then have them come and feel, not included. I think that could really work against your efforts. And so providing, a really, really inclusive environment, welcome committee, I think these small things can really make a huge difference and can go pretty far. Social events, opportunity for opinions and ideas to be heard. Part of the inclusion definition, you're really, you want people to feel valued, heard, respected, and how do you do that? So town hall meetings, as I mentioned, the social events, people having an opportunity to get together and express themselves. And then patient advocacy, community service, things like support groups. We've started a CPAP support group at our clinic, and then I'll go on to kind of wrap things up by talking about patient-centered DEI initiative that we've worked on. And so this is called the Compassionate CPAP Service. The goal was really equitable access to care for our sleep apnea patients that are uninsured or underinsured. And as we know, these are some of the highest risk patients that not only have slow time to diagnosis, but often do not go on for treatment. And so this program identifies patients who are uninsured and underinsured. We refer patients to this service, and we're able to provide CPAP supplies through our charitable programs or directly through durable medical equipment companies. And so this program has sort of evolved over time. Pre-COVID, we had a patient donation exchange program where patients with sort of a surplus of supplies were able to donate supplies to patients that didn't have supplies. And that worked out nicely until COVID hit. Pre-COVID, we also had charitable organizations that would donate refurbished machines to patients. And then post-COVID, we sort of pivoted and had DMEs more involved, and they actually had indigent patient assistant programs that we were able to provide to our patients and enroll in these programs. And then post-Philips CPAP recall, a lot has gone on over the last several years for sleep specifically, but we kind of lost, we didn't have that supply, so CPAP supplies were sort of very sparse everywhere. And so a lot of these DMEs stopped providing that service, unfortunately. And so we had to look at other avenues. And thankfully, we were just funded by the Community Sleep Health grant, so the AASM Foundation. And now we'll be able to kind of bridge that gap, at least for the year, until these DME programs are able to reinitiate their assistance programs. And so this is just an example of some of these sort of more patient-centered DI initiatives. And so just to summarize, I think surveying the climate is probably the most important thing to get a sense of what people, where they are now and where they want to be in your programs with respect to DEI. And then having these areas of DEI focus. And that will evolve over time, things that you'll be focusing on. And so I'll stop there in the interest of time, but I guess we'll take questions. Thank you.
Thank you, Dr. Asari, for a wonderful talk. So we are at time at 3:15, and I want to make sure that I'm not making people late for the opening reception or opening plenary session here. But maybe I'll say, if people have questions, you're welcome to come up, and I'm sure our speakers are happy to answer some questions in an informal way. Thank you very much, everyone.
Thank you, guys. Tell us who you are. Hi, nice to meet you.
So the self-assessment for diversity, what type of question do you use for inclusion? Because I can ask somebody, do you feel included? I'll say, yes, I feel included. But there's another way we can ask them, are you included in any board, any leadership group? Did you support any decision? So how do you ask?
That's a good question, because we did this 4 years ago, and ask the other questions, because I may be able to give you a very quick answer on that.
Okay,
So, because I should be able to pull up exactly what questions we asked.
That'll be great.
Yeah.
All right.
Hi.